I'm sure others will join throughout, but let's get this going. Good evening, everyone. So my name is Luke, here, your host for this fantastic virtual event as part of Psoriasis Australia with the support of Novartis. I hope you all had a really good day today. I know it's been a very fun and busy day for me as well. Tonight we bring World Psoriasis Day to a close for 2020, and we have three very special guests to help us all be that little bit more informed about the condition that over 1.6 million Australians live with on a daily basis. So first up, allow me to introduce Rebecca Nguyen, a consultant dermatologist in private practice who also holds appointments at Monash Health, Eastern Health and the Skin Health Institute in Melbourne. Dr. Nguyen has an interest in inflammatory skin disorders, including psoriasis, and is also involved in both the Biologist Clinic and clinical trials at the Skin Health Institute. We also have Dr. Irwin Lim, a rheumatologist in private practice in Sydney since 2003. For the more than 500,000 Australians where psoriasis is more than just the skin. He's a co-founder of BJC Health, which consists of a team of rheumatologists and allied health professionals, combining their different skills to develop effective plans to help people suffering with rheumatic disease regain control of their lives to become the healthiest version of themselves. And last but certainly not least, we have a representative from the community, Sarah Ridsdale, 39-year-old hospitality professional from Melbourne, diagnosed with psoriasis at the age of 2 and has lived comfortably with it since 2006. So just in terms of some quick housekeeping, we will have time for some Q&A at the end of the session, and we thank you all for those who have already put questions on our social media. We've been keeping track of those as well. So please, in the chat box, post any questions that you might have. We won't be able to see or hear you, but we'll do our best to get to the answers that you seek if you put them there in the chat box. And just so you know, this session will also be recorded and placed online afterwards via social media and the Psoriasis Australia website. So with all that being said, let's get started. Let's kick off with a bit of an easy one, I suppose, or maybe it's not so easy. Can you just explain, maybe Rebecca, start with you, nice and simply, what psoriasis is?
All right, psoriasis is extremely common, as is discussed, and about 1 to 2% of the population have it. It's a chronic inflammatory skin disease and has a multitude of manifestations, but most present with what we call chronic plaque psoriasis, which is a classic pink scaly plaques on the elbows, knees, scalp, and sometimes, the belly button, the buttocks, which can be quite visually disturbing to some people. And it can be quite itchy and sometimes painful, and it can really bother people. Other people do have different manifestations of their psoriasis, including nail disease, where they get quite deformed nails with pitting and sort of damage towards nails or discoloration of the nails. And then some people also do have quite severe scalp psoriasis or even genital psoriasis, which are certainly present as well in many patients. Present at any age, and it can last for many years and can be a lifelong condition.
Yeah, and Irwin, of course, we're here for psoriasis, but also to talk about psoriatic arthritis. So could you, talk through what that can entail as well?
I suppose I'm here because psoriatic arthritis is related to psoriasis, and it's a type of arthritis where the immune system essentially is a little bit disordered, a little bit angry, and it's attacking joints and surrounding tissues. So it's an autoimmune form of arthritis where the problem is excessive inflammation, okay? And psoriatic arthritis is a little bit of a poor term because it's much more than arthritis. And when people talk about arthritis, they think about joints. But one of the key features of psoriatic arthritis is that it can involve so much more than joints. And often it might be inflammation at tendons, at ligaments, at the spine, at the chest wall. So it's a serious form of arthritis where, as I said, the problem is excess inflammation at these sites.
And look, these conditions, they can present quite differently for different people, and they can change as one journeys through life. So, Sarah, you were diagnosed at quite a young age with psoriasis. So, what can people expect?
Oh, what can I expect? Yes, I was diagnosed at the age of 2. Psoriasis, it can develop on people differently. Personally, I was pretty much covered in it. So teenage years were pretty hard. Get emotional talking about it sometimes. yeah, you just kind of learn to I don't know, you kind of create a barrier. Like I always smile and I'm always the funny person because I just, yeah, I don't want to, like, people looking and stuff like that, cover up. Always wear white, never wear black. But yeah, it's different for different people, but I know it's pretty traumatic for some people.
Absolutely. I know we hear so much around how psoriasis, it does present so differently, and different symptoms present for different people, and it can be impacting different parts of the body for different people as well. So it is quite a tricky one. I guess, Rebecca, what are some of the other flags in terms of psoriasis that people, look out for and that you sort of see in your role as a dermatologist?
Our role as a dermatologist is that we see a whole spectrum of different patients with different manifestations of psoriasis, very mild disease to very severe disease. And I think it's about recognizing people's how people are affected by the disease and trying to help them through that journey with their condition of psoriasis. But then there's always recognizing early on the potential crossover with psoriatic arthritis. And I think there's certain manifestations such as severe nail disease, severe scalp disease, may potentially lead to an increased risk of psoriatic arthritis, which Irwin well knows, and he can probably elucidate further on that as well.
Yeah, absolutely. And Irwin, talking about, the symptoms people can look out for that could lead to psoriatic arthritis. I mean, this is a disease, I think, that many people don't know that, up to 4 in 10 Australians with psoriasis do develop psoriatic arthritis. It's an inflammatory disease of the joints associated with psoriasis. I guess in your experience, what are the signs when this is occurring? And I guess what are the kind of things people should watch out for if they have psoriasis and they're concerned about developing this other part of the disease?
Yeah, it's a good question, and obviously one reason why we're here to talk about it. And it's difficult because often at the start, it's not obvious, okay? And when people, let's say, present with that excess inflammation at a tendon, think about an elbow pain, right? Common tennis elbow. The tendency will be to blame exercise or sport or whatever activity you do. And so I think at the start, it's actually really difficult because it can be any other reason for it, okay? It's an accumulation of clues. So if you have one tennis elbow, then it's recalcitrant, and then you develop another tennis elbow, or you get your plantar fasciitis or heel spurs, and you seem to be someone who keeps breaking down with tendon injury. That's the time when the physio, the GP, the orthopedic surgeon will hopefully start thinking about it. Because most people living with psoriasis, the skin disease, will never associate the skin with a tendon problem, right? It's easy if it's a joint that's big and swollen, right? So if someone presents with a knee that's swollen, surely someone will work it out. But most often it's more subtle. If you present with a little bit of ribcage pain, there's so many ways to blame it, on other things. If you present with back pain, it will invariably be, if you're male, it's because you played sport or you lifted something, a stupid weight that was too heavy, or you did it at work, right? If you're female, they'll blame it on poor core stability, or having a baby, or being overweight, or if you do a scan, which 20 to 40% of people will have abnormalities on, it will be blamed on that. So I think if it's subtle, if it's not in your face, it's very easy to miss, which is why 5 to 10 years may pass before a diagnosis of psoriatic arthritis. So I suppose why I agreed to be here is because the whole aim is to try to get the message out that if you make a diagnosis of psoriasis, and if you have psoriasis, you then just have to be aware that there's the possibility of joint, tendon, spinal problems. And if whatever you get doesn't resolve or get cleared up quickly, to then try to get a diagnosis.
That kind of answers my question. I was actually going to ask what my chances would be, considering I've had it most of my life and quite badly, and knowing that there's other family members that have psoriatic arthritis.
Yeah. So Sarah, I mean, obviously I don't know your history, but for someone who's had it for a long time, and I think you alluded that it was quite bad initially, and you had nail disease, your chances are high. So if the rough numbers I have in my head are 3 to 4 out of 10 in general. But if you have nail disease, if you have bad, genital disease, if you have it badly in your scalp, umbilicus, between the bum cheeks, that risk goes up to about 80%.
Yeah,
okay?
right.
But it might not be severe. It might be a bit of inflammation of the back. It might be a sausage finger, a dactylitis. So it might not be, crippling disease, but it can be an annoying, irritating, recalcitrant type disease. Right?
All right. I have one of those, so I may have to come and see you.
And Irwin, people say that an early diagnosis is important. Why is that?
I suppose if you can tell people what they have, they can make steps to try to help it, right? And you can have a proper management plan. So I've already said that there's a delay of about 7 to 10 years. So if you can have an earlier diagnosis, you save people suffering, you save people wasting time on, treatments that might not work, and you at least help people understand what's going on. So I think, there's a lot of value in that. Now, if they have serious psoriatic arthritis or tendonitis or enthesitis, which is where the inflammation is at the ends of tendons and ligaments, if it's serious and there are bad factors that suggest it will progress, then you also want to treat more aggressively to prevent long-standing damage or deformity. You want to stop things before you accumulate damage that you can't reverse. Okay, and I do want to make the point that's not the majority of people, but if you can at least have the diagnosis earlier, you can be monitored and treatment started when appropriate.
And can you elaborate a bit on those specific risks that can happen if diagnosis is delayed, especially given it can take years for it to be, correctly diagnosed? As you said, people will have all sorts of pains and things that they write off as, oh, it's just sport, or I moved house last weekend, it's nothing. So, what are some of the risks of if the diagnosis is delayed?
Yeah, and so this is where this is a complex disease because it depends what is affected, right? So if you have swollen joints, and usually if it's swollen joints, it'll be diagnosed earlier. Because if you've got painful swollen joints that you can't move, you search out a diagnosis, right? If you can't control that or you ignore that, the swelling and the fluid that has chemicals in there that actually lead to eating away of the bones, of wearing out of cartilage, so you get accelerated joint damage. So that's number one. Number two, if you have a lot of tendon problems that are not diagnosed, right? Then basically your activities change. You may stop exercising as much. You may find that you can't use your elbow, if I give you the example of tennis elbow again, which then means that you'll overload your shoulder and your wrist, right? Which might mean that you then throw out your neck. So you'll accumulate problems. And of course, if people live in chronic pain and never get a solution, it affects work, it affects mental health, emotional health, it affects what you want to get out of life. So those are major things. My particular interest is spine, right? And if it affects the spine, it leads to a stiffening and a loss of mobility. And that can then, of course, lead to all sorts of other problems.
Absolutely. And look, let's talk about, managing these conditions. It can be quite complex. So I was wondering if we could just talk through some of the ways that people can lessen these impacts in their life. So, I mean, Sarah, what have you been doing? You've had it since a very young age to manage psoriasis. What are some of the things you've been doing to help, manage those conditions and lessen those impacts?
Yeah, so diagnosed with it at the age of 2, and about 80% of my body was covered. So I did have it pretty bad. I've done light box treatment. I've changed my diet. I've done all that kind of stuff. More recently, I was lucky enough to get onto biologic, and that has been my godsend. But still, even with that, I've still got some plaque psoriasis on my scalp. I still get little patches here and there. I'm just constantly putting cream on. I suppose when you're so young and you're diagnosed with it as well, it just becomes second nature to just constantly be like covering or touching and all that sort of stuff, and just making sure that like everything's covered up, or you've got cream. There's always a tube of something in my bag. But yeah, like I'm doing really well at the moment, and I'm really, really happy. But yeah, I just worry about those that aren't getting the help that they need.
Yeah. And Rebecca, I guess from the, psoriasis side, what are some of the things that you can suggest to help to lessen those impacts?
I think there's quite a lot of practical things that can be done to lessen the impact of psoriasis. And I think the first thing is developing a good therapeutic relationship with a physician of some sort, being initially maybe the GP, but if it's becoming more severe or more chronic or lifelong, it's a specialist such as a dermatologist for skin or rheumatologist for psoriatic arthritis, and really discussing the symptoms and the signs that you're developing and how they're impacting your life so that you can move forward with your management, and really having that frank discussion about what you really want out of the management, because that can sometimes influence the doctor's decision on where you go from there and the patient's journey of their treatment and management of their disease. As Sarah's alluded to, there's a lot of new treatments available in the last 5 to 10 years that weren't present maybe 10 years ago. And we have a lot of patients who are disengaged with mainstream medicine and have failed to see any kind of GP or specialist about this condition because it's been dismissed multiple times over the years in the past that you can't do anything about it, and come to us quite severe actually by the time they actually even see the specialist for the first time. And we tell them about all these new options available, and they're really quite amazed because they've never heard about any of them previously. And so I think that's probably the first thing. I think the internet and forums like this and support organizations and social media has really opened up people's ways of finding out further information. So I think it's always wonderful that people are connected with their social medias. I think I don't have an issue personally with patients looking up things on the internet, because we get patients all the time saying, well, I heard about this thing on the internet. Is it real? Does it exist? Is it right for me? And I think having that good relationship with a long-standing physician, it helps you sort out what's the truth, what's the fact, and what maybe is maybe not so truthful as well.
Yeah, and you talk about community there, Rebecca, which I know is so important with diseases like this, to have people that can rally around you and share stories. Sarah, I'm sure when you were growing up, there were things that you were told and wanted to know about this disease that you wish you'd known.
Yeah, most definitely. I mean, I was lucky enough that my parents were really pushy when it came to like going to find the right doctors and stuff like that, and thank God for them. I've got my dermatologist who I call God. I absolutely love him. But yeah, growing up, I wish there was a lot more information. I was really alone, really alone. But yeah, thanks to things like this, thanks to Psoriasis Australia, I can talk to people that have got it or get ideas of what to do if I have another flare-up, as I have a scratch. But yeah, no, it's the doctors and the dermos and stuff out there that are also getting educated on it. And that's the thing. We need more of them to know what this is and to push us in the right direction if we're willing to do these different sort of medications and stuff. I think it's really important. It changes your life.
And Rebecca, Irwin, as professionals, I'm sure you get all sorts of patients coming with, I've heard that if I stop eating this, I'll feel better, or if I, change this part of my life, I'll improve my psoriasis or psoriatic arthritis drastically. I guess, are there particular, old wives' tales out there that people shouldn't believe, or are there anything that you think is really useful information for people who are coping with this disease?
I'll start briefly and then Irwin can take over. Look, I think old wives' tales are always steeped in some element of truth, so you can never dismiss anything completely. I think there are definitely lifestyle modification in terms of eating a healthy diet, balanced diet, reducing your high fat intake are all important to your overall health and all important to your cardiovascular health, which is in some degrees related to your sort of psoriasis as well. And so I think these are all very important factors in addressing things like smoking, alcohol use, their mental health, and their overall well-being will help overall their psoriasis. I think even just with this year with the COVID-19, definitely seen with increased stress levels and inactivity and going outdoors less, because sun exposure does improve psoriasis to some degree, has flared up quite a number of people with psoriasis, and which they haven't had a flare for good 3 or 5 years. So there are, environmental factors and social factors which definitely influence our disease. I'll let Irwin keep going.
Well, I agree with you, Rebecca. I'm actually very pro lifestyle factors, right? So even if I have to treat someone with a medication, I'm still pro lifestyle factors because it might help get better control, might allow me to taper the medicines in time, might reduce side effects, might reduce fatigue that tablets typically don't work very well for, and even the biologics, often don't help very much for. So I think the mental health is very important. In terms of diet, I actually think it makes a difference. I think exercise, we keep saying this, but exercise and movement is good for arthritis. It's particularly good for inflammatory arthritis. And too many people are actually wrapped up in cotton wool or are too afraid to do it, unless you're being silly or you are an Olympic athlete where you're training despite being in pain. You're not going to harm yourself generally. So I think the keep moving idea is a good one. Now, it's very clear with psoriasis and psoriatic arthritis, body fat's a problem, right? If you look at all the trials, as a general group, psoriasis patients, psoriatic arthritis patients have BMIs, around that 30 mark. And again, there are some intriguing studies where just losing a large amount of weight helps the skin and the joints and the tendon disease. And it's not just mechanical, effects of weight. It's actually fat cells, particularly around the abdomen, create all sorts of cytokines, which are chemicals which help the immune cells communicate. So that's really important. The difficulty is it's obviously hard in our community to it's not, as a doctor, just saying, oh, go lose weight. That's not helpful, right? Because there's always other reasons around weight gain, and sometimes it's the drugs as well. So, but in someone who can do it, and it's exactly why we set up a clinic with dietitians and to try to help those who want that type of help. Many of you on this panel might have, and participants here might have seen a naturopath or a holistic doctor, and they will always say three things, right? Reduce your lactose, reduce the sugar, try to reduce gluten. And I think a lot of people with immune diseases feel better with that anyway. So I don't mind people trying all those. I myself, I reduce a lot of those things. So I think that's easy things to do. But yeah, by the time you come to see Rebecca or me, typically we also need to do something else, right? It's not going to be cured by a diet unless it's a radical, some radical fecal transplant where there's no real good evidence, or people have obesity surgery and lose heaps of weight and then suddenly the inflammatory arthritis disappears. We always hear these odd stories, but in general, we need a combined approach by the time someone comes to see us.
Yeah. And Rebecca, you mentioned just before, COVID and how that's affected the year and how it's affected people's mental well-being as well. So Sarah, I imagine, living with any form of psoriasis, dealing with, day to day, having that treatment, having those concerns throughout your life, what was that like for you?
COVID was pretty interesting actually, because when COVID kicked in, there was troubles with the chemists getting in a lot of their medication. And I was one of those people that suffered that. So the beginning of COVID was really stressful, being hospitality in Melbourne, first to lose my job. So lost it back in March. So the stress just went through the roof. Wasn't getting my medication and I had massive breakout. And just didn't think that I would be able to get it back under control. But yeah, sort of I've come through. We're at the end, first day of work today, feeling good. I'm back on my medication. So yeah, I'm okay I'm okay at the moment. I just, I really want to know what people out there that aren't in the same position as me, just a couple of steps in order to kind of, get them motivated to go and speak to somebody, and who should they speak to?
Yeah, and that's a good point. I mean, Rebecca, Irwin, is there sort of early signs to watch out for? What sort of stages should people be thinking about in terms of escalating to get that support with their psoriasis?
I think we always try and emphasize, especially to our chronic long-term patients, that if there's any issues or concerns, they should contact immediately, or contact a specialist, or even have a chat over the phone if it's during COVID and they don't feel comfortable coming in, or video health, sending photos in, and then coming in if it's really necessary. And a lot of patients are still coming into our clinics even throughout this whole period, because the psoriasis clearly impacts their quality of life, and it affects their ability sometimes to work or to interact with others, or and their mental health. And I think it's important to gain control, and a good therapeutic relationship with their doctor is important. And that way we can always look at early signs such as if they're increasing symptoms, change in their disease sites, or is there some issue with their treatment or side effects, that we can change quickly so they don't lose control of their disease and it becomes more difficult to get on top of it over the next, months to years. I don't know what Irwin thinks here. I'll let him talk.
Go for it.
Oh, no, I agree completely with you. I'm in Sydney, so a bit more fortunate. We've been very busy. The anxiety levels, we have some opposite problems where people just stop their drugs because they were so scared. And that has led to a flare rather than them not being able to get the drug. But we've been very busy. There's obviously been a rebound. I think also spending hours in front of Zoom, people are getting all sorts of musculoskeletal aches and pains. So among our patients, there's definitely a lot more coming in.
Yeah, definitely a bit of a change of habit and routine for a lot of people. Less moving around for sure. All right. Well, I think we're getting close to time for this part of the session. I am conscious it is almost the end of the session we had planned. However, we will go a bit longer because there are some community questions. But for those who do have to drop out, we will, again, this is recorded and it'll be posted online afterwards. So if you do have to leave, you can go online and see the rest later. But I do want to go to the community questions a little bit. We've had some questions come through in the chat as well. So somebody has asked in regards to how do you actually diagnose psoriatic arthritis? Is there an X-ray? What is that process like?
It starts with symptoms, right? So if you don't have pain or stiffness or joint swelling or I suppose pain and stiffness would normally bring someone to attention. So that's the starting point. Then obviously a history. If the patient who sees a GP, if that GP is cluey, has psoriasis, it needs a high index of suspicion. If the patient complains of pain or stiffness to someone like Rebecca, she'll be thinking about it because she's already in tune with it. The difficulty is if the patient doesn't mention it, to someone like Rebecca, right? And then whether we go looking for it. Because obviously, as a rheumatologist, I speak to my dermatology friends in Sydney, and we hope that there's some screening of their population given such a high likelihood of their patients getting it. Now, how do you actually diagnose it? It's a little bit of detective work because, as I said to you, it depends how it presents. If it presents with a nice big swollen joint, it's easy, right? Once you rule out a few things, it can only be that. If you present with a tendon or two, problematic, or a little bit of back pain, it's a little bit harder because it can merge with lots of other mechanical issues. So it's the history, the examination, and then focus investigations. So for example, with the spine, I will often, if I'm not certain, need to do some radiology. And it depends how long. If you've had back pain for 3 months, there's not going to be any X-ray changes. So X-rays would be a waste of time, right? I would need to ask for a specialized MRI looking for inflammation within certain parts. If it's a tendon, depending on where it is an ultrasound place which has an interest or an expertise in reading them can tell me some features on an ultrasound that will be suggestive. Okay. And again, X-ray, unless it's late disease, will not really help. So I think what investigations we do will depend on what we actually find on examining and the actual story. It's not as easy as just telling your local GP, unless they have a particular interest, to just do any old X-ray. And, just a negative X-ray does not exclude the disease. Let's put it that way.
Absolutely. Thanks for that, Irwin. I think we've had some other questions. I'll try and sort of theme them together, but somebody's asked about their daughter, being only 7 years old, was diagnosed with psoriasis at the age of 4. We've had some questions on social media as well about kids. We know there are plenty of kids. I mean, Sarah, yourself, you were diagnosed quite young with psoriasis. Is there a particular age where they can start looking at diagnoses for psoriatic arthritis, or is it really different for everybody?
So firstly, I'm an adult rheumatologist, so we see usually people 15 and above. But my understanding is that psoriatic arthritis is actually much less often common in a younger age group. And yes, you can get aches and pains, but they don't tend to get, it would be rare to get the type of psoriatic arthritis that we would be worried about as treating rheumatologists. But my disclaimer is that I'm not a pediatric rheumatologist, but that's what I understand.
Yeah, and we've had some questions in the chat, but again, a big theme on social media where we first talked about this webinar, talking about GPs and, you know, specialists and dermatologists and their understanding about psoriatic arthritis. There's a lot of discussion around how some doctors are, you know, maybe not as informed or maybe potentially dismissive of psoriatic arthritis or don't even know that much about it. So I guess, is there something you can recommend or thinking about how we can get this changed? It's a tricky question, I know.
It's a big question. When I go to a dinner party, most people don't know what a rheumatologist is, right? So they know what a cardiologist is, what a dermatologist is. So that's the first problem. So we suffer from an awareness issue. All our diseases suffer from an awareness issue. You know, rheumatoid arthritis, osteoarthritis, psoriatic arthritis. People don't know what they are. Medical school might spend 1 week on rheumatology and focus more on you know, heart, lung disease and things like that. So unfortunately, I don't see that changing anytime soon. The boon to people will be social media, right? And the internet and the awareness, right? And what we're actually hoping is that, I suppose we would hope that our awareness programs to GPs will help, but it's difficult because GPs get messages from every specialty group. And it's such a hard job. So while, you know, I do appreciate GPs don't know a lot about this, I think they have a really difficult job, to be honest. So it's difficult. What we hope is that more dermatologists as well will screen, because obviously dermatologists see a lot of patients with psoriasis. Rebecca's different. She's obviously in an interested group and a different type of clinic. In Sydney, at least, in the vast majority of community dermatologists, psoriasis might not be a particular interest. So it's how to get that screening message in, how to get that education piece in, right? So that when you diagnose psoriasis, you tell people they have the risk of this, and then they need to look out for it.
Absolutely. And another sort of theme that's come through is, I guess, how treatment can change for people, how, you know, you might be on one particular medication or one line of treatment, and then that could potentially stop working. And then you've got to change to a different kind of treatment. I guess, you know, is there anything regarding, I guess, ongoing treatment that you see as kind of a common occurrence? Is it usually the treatments will work for a while then stop working, or can you talk us through that a little bit?
Rebecca, do you want to handle it?
Yeah, so I think that's where it comes to with the therapeutic relationship with a physician or specialist is really important, because they know your background history, they know what's worked for you in the past, what hasn't, what side effects you have. I think the treatment paradigm has really become a lot more complex over the last 5 to 10 years. There's a real explosion of new treatments available for both psoriasis and psoriatic arthritis. Some of them cross over, some of them don't. This is when it gets very tricky, because patients get put on one drug by one specialist and then a different specialist wants to put them on an alternative drug. And that's when you need communication between all their different specialists and their GP to co-manage them appropriately. And look, we always have a friendly, discussion with our rheumatologists who manage some of our patients about, we want to switch into this drug. Would they be happy with that? Would they not be happy with that? And how is that going to affect their arthritis, not just their psoriasis? Because we have actually had patients who have done, lost efficacy on one drug with the psoriasis, switched them to a different drug, and then their psoriatic arthritis becomes out of control. But their psoriasis is well controlled. So it becomes a lot more complex than just saying, oh, drug A doesn't work, so let's just try drug B, and it's all going to be fine. And so I think that's where there's always new studies coming out, new information coming out every single year with large clinical trials about, which patients are best for what drug. And I think as medicine becomes more specialized, and they start doing more testing, they can maybe in the future, and this is a hopeful future, that different types of psoriasis, psoriatic arthritis can be really categorized, and therefore patients are put onto the correct treatment earlier on. Because there are, as we know, even just with normal psoriasis, very different forms. There's plaque psoriasis, pustular psoriasis, hand and foot psoriasis, scalp genital inverse psoriasis. And they do respond quite differently sometimes to the different medications available out there. And there's always new medications coming. I mean, even now, there's still clinical trials being run on new tablets, injection therapies, other forms of topical therapies for psoriasis in the next couple of years. I'll let Irwin continue about psoriatic arthritis.
Yeah, because there were questions come through in the chat as well around, if there's a blood test or some other way to diagnose psoriatic arthritis in that sense as well to help people out.
Okay, let me answer the blood test issue. Look, you can measure inflammatory markers, but we don't have any specific autoantibodies for it. And psoriatic arthritis is part of a group of diseases called seronegative, blood test negative spondyloarthritis. So a negative blood test does not rule out the disease. Okay, a positive blood test may be helpful, but it's not diagnostic either. So blood tests, right? It's usually to use it to rule out other things and maybe see some inflammation, but it's a clinical diagnosis plus or minus radiology that's appropriate for it. To come back to the previous topic, the interesting thing about this disease and the difficult thing about this disease, it can present in so many different ways in different people, right? And so that person who has a bit of scalp disease, a bit of elbow disease, but has terrible nail disease and 2 fingers that are swollen like sausages and the back, there's no one medicine that's going to treat all that, at least none of the older style medicines, right? So if we talk about an old favorite methotrexate, it might help, the skin, it might help the nails a little bit, it might help the joints a bit, doesn't really help so well with the dactylitis, doesn't touch the spine. And people need to understand that. And that's why there's combinations of medicine. And so when people say something doesn't work, well, number one, it might not work. Number 2, the disease might be getting worse because it's not well controlled. Number 3, adherence or compliance with the medicine can be quite fluctuating. In most studies, most people are maybe 60% compliant or adherent at any one time, or it might not be the right mix of medicines. And unfortunately, we are not precise yet. It would be far better in 10, 20 years when I can look at Sarah, do a blood test or a breath test or a urine test or a poo test and say, well, drug B is the right one for you at time C, right? But we don't have that yet. It's a little bit of cookbook medicine at the moment.
And we've got a couple more questions before we sort of wrap this up for the evening. But we have a question around, how long should someone wait with trying things like supplements and natural solutions before turning to medications? Is it a good idea to rule out those natural things first, or is it better to go and get diagnosed as soon as possible?
Okay, I might start first. It's very common for me to have this discussion. And if someone's very anti, let's say, pharmaceutical medication or the things that I've started to talk about and wants to try Ayurvedic medicine, naturopathic medicine, Chinese medicine, I said, no problems. Let's not end the discussion there. Just give yourself a defined period of time and don't lie to yourself. Okay, whatever you want to try, do it. Give yourself 3 months. Let's not mix everything together because you won't have any idea. Do whatever you want and just don't lie to yourself. If you're not getting better, come back. Let's have another discussion. If it's working, fantastic for you. So that's my approach. I don't try. If someone's clearly wanting to try it, I don't try to shift them.
And I guess one last question for you, Sarah, as well, in terms of, living with psoriasis, and you said, growing up as well, especially, it was quite difficult. It's a visible thing, and people are ignorant sometimes to certain conditions, and kids especially, they don't really know, what psoriasis is. So
yeah.
Is there stuff you say to people today if someone, is looking at your skin or they're confused about what it is? Is there like a sort of a good method that you have to kind of inform them and educate them, given the theme is Be Informed this year?
Yeah, totally. Well, when I was really bad, it was all over my face. I had it I looked like a butterfly on my face and I had it all down my arms. And people would just stop and look. I wouldn't often be uncovered, but 40 degrees in Melbourne, you'd have to wear a t-shirt and people would just kind of stare. And I'm just bubbly and open, and being in the hospital industry, got it, like people, you're on show all the time. And I'm just like, it's not contagious, it's okay. And that would just open this dialogue. And people would be like, oh, I'm so sorry, but you know, what is it? And then I'd let people know. And so many times it would be like, I've seen it on my niece, or a friend of mine's got something that looks similar and she doesn't know what it is. And so it was really cool in that way, because I would then say, go and see a GP and just ask to see a dermatologist. just go to your GP and say, can I see a dermatologist? I need to talk to somebody about my skin. And it was great. And I've had people come back to me that, like, we've kept in touch and have just been like, yeah, it's worked out really well.
Awesome. Well, thank you so much, Sarah. And I think we could keep talking, all of us, about psoriasis and psoriatic arthritis all night, but we will end it there. But I wanted to thank everyone for joining this Psoriasis Australia live virtual event on the evening of World Psoriasis Day 2020. Special thanks to our panelists tonight, Dr. Rebecca Nguyen, Dr. Irwin Lim, and Sarah Ridsdale, and to Novartis, who supported us in bringing this to you. And mostly a big thank you to all of our community, all of you, for bringing our questions to this group. I'm sure we're all going to leave tonight feeling like we've embraced the 2020 theme for World Psoriasis Day 2020, which is to be informed. If you missed any part of tonight, you want to come back for more tips or to share with friends and family to help them be more informed too, we'll be posting this to the Psoriasis Australia Facebook page and on the website. And there were some questions that we didn't get around to tonight. There were lots of great questions. So I know the Psoriasis Australia community is a fantastic one to ask questions, share concerns, and I'm sure you get some great responses from the community there as well. So thank you, everybody, and have a good night.